Good afternoon and welcome to our virtual weight loss seminar. My name is Jesse Gutnick. I'm one of the bariatric surgeons. I'm joined here with a great panel. Jamie Sarver is our program coordinator. Beth Foster both works in our department and is a patient of ours. And Dr. Strong, who can hopefully make it, he's still in the operating room, is another one of our bariatric surgeons. So if not for his portion, at least hopefully he can make it for a Q&A. So a brief agenda. We're going to hear Beth's personal story. Then I'm going to talk a little bit about the science behind how weight loss surgery works. And then Jane will be talking about what to expect within our program. And then we'll have an option for Q&A. You can send in your questions at any time via the chat function. Send it to all panelists so they can see them. I'll be reviewing them and moderating that Q&A at the end. So with that, I'll hand things off to Beth Foster.
Hi everyone, my name is Beth Faulkner. I am actually a nurse coordinator for a bariatric program, which happened after my surgery. I had gastric bypass surgery June 21st last year, so I'm about 11 months out right now. I have been a nurse for over 20 years, and I will admit that I used to think weight loss surgery was an easy way out, but let me tell you, that is not the case at all. It's an effective way to lose and keep off weight, and it requires quite a bit of work and dedication to the process, just like any other weight loss plan does. Only you have the extra benefits of the surgery, which Dr. Gutnick will go over later. I started looking into weight loss surgery probably about 10 years ago. I actually started the program 3 times before I decided to actually go through this surgery. I had never had surgery before, and I was nervous, and I just wasn't ready to make the changes necessary. So this last time I started the process, probably, I think it was December of 2021. It takes a while to get through all the different testing and appointments, because you need to be determined that it's safe for you to have surgery, and you need to be prepared for the changes that you need to make afterwards. A little bit about my history. I've always been overweight as a child, as a teenager, even when I was doing sports and was pretty active. Obesity runs in my family, as does pretty much everything associated with obesity: high blood pressure, heart disease, cancer, diabetes. So I was at a disadvantage. I have tried every weight loss plan and program there is out there. I never tried medications, but I did all the other stuff. I exercise pretty regularly. I would lose some weight and then I would gain it back, and sometimes I would gain back extra. And it was very frustrating. And I'm 45 now, and as I've gotten older, it's been harder and harder to lose weight. And what really prompted me to look into surgery this time for real was I started having more and more health issues. I've had reflux for a while. I started having to take high blood pressure medications. I was diagnosed as a pre-diabetic and put on metformin. I've always had migraines, but they started becoming worse. I just all over, not feeling well, joint and back pain. I've never had a normal period in my life, and we were never able to get that under control. I always blamed my pains on being a nurse, but I'm pretty sure that was not the case. So I started the bariatric program in December 2021, like I said. I had multiple appointments with nutrition, psychology, and medical appointments. Like I said, there are groups that psychology puts on to help you learn to make the changes that are going to be necessary, because especially for me, a lot of my weight loss was part of weight issues were by my relationship with food. So there's a lot of focus on learning how to adjust your eating, adjust your coping skills. So once I was finally approved for surgery, 2 weeks beforehand, I had to start a high protein liquid diet, a full liquid diet. And what that does is it helps to decrease the size of your liver to make surgery a little bit easier for you and your surgeon. I had already incorporated protein shakes and a lower carb diet into my life at that point, but I will tell you that first week of that 2-week diet can be really really rough as you're adjusting to the lower calories, the change in nutrients. But the second week, thankfully, is much easier. My body had adjusted, and honestly, it was hard to get all the shakes in, even though that's the main source of your nutrition. Like I said, my surgery was June 21st last year. I was in the surgery area for about 2 hours. I spent one night in the hospital, and I was home by the afternoon of the next day. Thankfully, while I was in the hospital, I didn't have a lot of issues with pain, and I was able to tolerate my fluids. So there's a lot of variables that go into how quickly you're able to get out of the hospital. I was sent home with some prescription pain medication, just a little bit, but I will be honest, I hardly had any real pain. I think I took about 2 of those pills, and honestly, Tylenol did a very good job of controlling my pain after that. The first week after surgery was definitely the hardest. You have to learn to drink differently. You have to learn to sip, and you have to sip all day long to make sure you're getting in 64 ounces of fluid a day and getting in your protein shakes. People laugh when I tell them it becomes kind of a full-time job, but it really does. I was also started walking again right away after surgery. It was short distances and a couple of times a day if I was up to it. And every few days I would increase it a little bit more. I would say after the first week, I felt pretty well. I did have a lifting restriction for 4 weeks, and I was not able to go back to work for 4 weeks because as a nurse, I couldn't have any restrictions. For the first couple of weeks after surgery, for the first 2 weeks, you're on a full liquid diet. It's similar to the diet you're on beforehand, except that you can use different shakes. After that is a 6-to-8 period of pureed and soft foods. This is a lower carbohydrate, high protein diet because you don't have a lot of room in there and you need to focus on meeting your protein goals. It includes mostly things like soft meats, ground meats, eggs, yogurt, tofu, beans. There's not enough room in there, so you need to make sure you're making it count for protein. After that 6 to 8 week period, you'll be working with your dietitian. We call it the phase 4 diet. And that's the diet you'll stay on until you meet your weight loss goal, which is something that you set up with your doctor. There's no set number for that. And after that, you'll meet with your dietitian, and they'll help you formulate a maintenance plan to help you keep your weight off and remain healthy and meet your nutrition goals. So my current weight is 185 pounds. I'm not on any blood pressure or diabetes medications. I have not had a lick of heartburn since my surgery. My periods have been regular for the first time in my entire life. I think I've had maybe 5 migraines since surgery, which is amazing for me. And honestly, I don't have any more back pain or any joint pain other than if I work out a little bit too hard. I am able to jog, and I never thought I would be able to do that. I can go up and down multiple flights of stairs. Haven't been able to do that since I was a kid. I mean, I could go up them, but I'm not out of breath now, and it's really nice. Next slide, please. So kind of a general post-op milestones. For the first month, like I said, this is when you learn to eat and drink with your new anatomy. You really have to be focused on meeting your protein and liquid goals because it's easy to get dehydrated and it's easy to get full too quickly and not be able to get your protein. After that, months 1 through 3, it's a lot easier to meet your goals. You usually have a pretty rapid weight loss. Your energy is much better than it is for that first month. And this is really a time to get super motivated into an exercise activity routine. It doesn't have to be exercise, it just has to be movement. Months 3 through 6, you're eating pretty normal at this time. Food is less of a chore. You get to have a good relationship with food again. Weight loss is still pretty rapid at this point, and this is a great time to start working on increasing your weight training, resistance training, build up some muscle that you may have lost early on. that's a really big focus in your exercise. Cardio is good, but weight training is very important. And I'm kind of in that, 6 to 12 month range right now. My weight loss is more normal pace now, 1 to 2 pounds a week, because you've already lost a big chunk of your weight. It's easy sometimes to forget to work on your fluid goals and to hit your protein goals. So you still have to keep focused on that. And since the weight loss has slowed down, this is a really good time to start focusing on what they call the non-scale victories. Your increased energy, your less pain, you're being able to keep up with your kids, you're being able to do things maybe you could never do before because of your weight. The biggest one for me was the first time I flew after surgery, I didn't have to use a seatbelt extender. I almost cried. It was amazing. So next slide, please. So goals after surgery. You really want to keep up with your activity, exercise routine. If you're getting bored, try something new. It doesn't have to be in a gym. It's probably better if it's not in a gym if you don't like the gym, Dancing around your living room, doing yoga, going for walks outside, hiking. Just change it up so you stay interested in it, so it's fun for you. If it's not fun, you're not going to want to keep doing it. You need to stay on your vitamins. This is very important. We talk about it throughout the whole program. The vitamins, because of the surgery, you are getting them from your food like you were, and you need to stay on them, even if you feel like you don't. Like you got to keep up with your fluid and protein goals. You can still get dehydrated. You're still going to feel miserable. Obviously, my eating is still very restricted, so I always eat my protein first to make sure I'm getting my protein in. And protein keeps you full faster, longer, and it helps me keep my weight where it's at. And keep up with your appointments. If you feel like your weight loss isn't going the way you wanted, or if you're starting to put weight back on and you're not sure what's going on, don't be afraid to reach out to your dietitian, to the medical team. If that's what they're there for. There are things that can be done to help you, and we're working as a team to keep everybody successful. And I think that's about it for my story right now.
Thank you, Beth, for sharing that. And remember, if you have any questions for her in particular, submit them via the chat. I'm going to talk about how the weight loss surgery operations work and how effective they are. So the way they work essentially is your body is designed to maintain your current weight, kind of like a thermostat in your house. So just like in your house, if you have your AC on, it's getting hotter outside, your AC kicks on to keep the house at a certain set temperature. Our body's hormonal balances are very much the same, where when you diet and you're taking less calories, your body adjusts to use less calories, and then your weight's maintained. So your body is almost designed, or really is designed, to fight your weight loss. The weight loss surgery reprograms how your body manages your calories, and this happens very strongly in the first year with some continuation over time, but with decreasing power over time. So you get to a new set point, and then your body wants to stay at that new set point like it wanted to stay at your old one. Going through some of the mechanisms that this works as. So your basal energy expenditure, that's how much energy you just use doing what I'm doing now, sitting here talking, not doing any extra exercise. When you diet, your body turns that energy burn down. And after surgery, that energy burn is turned up. Your appetite is increased when you're dieting because you're not getting the fullness signals and satiety signals in your brain, and those are turned down after surgery. Same with the sensation of fullness. Your stress hormones go up when you're dieting because your body thinks you're in some kind of really bad situation. After surgery, they'll actually decrease. And then some of the gut hormones interact with the rest of the body, including the brain hormones. And those go in the alternate directions as well. The two most common options, and the ones that I'm going to show the sort of scientific data for, are sleeve gastrectomy and gastric bypass. Not because they're the only ones, but they're the ones that have the most highest level of research behind which are randomized controlled trials. There's some other additional operations, including duodenal switch and revisional surgery, that we also, of course, offer. So these two comprise 90% of the weight loss procedures that are done nationally, and a little bit less of what's done here. The first one on your left-hand side of the screen is the gastric bypass. That gastric's just the medical word for stomach. So essentially the majority of your stomach is bypassed. And the second one is the sleeve gastrectomy, where your stomach is changed from about the shape of a half of a heart to about to a tubularized type shape. One of the most seminal trials in bariatric weight loss surgery is performed here, and it's called the Stampede trial. And this was important, number one, because it was a randomized control trial. So patients, when they enrolled in it, essentially an electronic coin was flipped and it was decided if they would go for the best treatment of their diabetes versus the weight loss surgery. And this was one of the landmark papers that really demonstrated how powerful these are for diabetes treatment. So if you want to look at this graph, the patients that were randomly selected to go to the best medical therapy are in yellow. The patients who had gastric bypass are in orange, and the patients who underwent sleeve gastrectomy are in blue. The up and down axis is the change in the body mass index, which is just a ratio of your height and your weight. And then the horizontal axis is the number of months after randomization where you were selected to do one or the other. And this goes out over 5 years. And so you can see the patients in the best medical therapy for their diabetes did lose some weight, and they also maintained some of that weight over time, about 2 BMI points. Sleeve gastrectomy and gastric bypass went down around 10 BMI points each, with a slow increase over time, which is about normal. And if you follow this out further, that plateaus over time. Similarly, and this is where this was very landmark, demonstrated how effective it was for diabetes. Again, people that had the best medical treatment were in yellow, and they had a good improvement over the first 6 months to a year, and then over time they went back up with their A1C about to their baseline. Whereas the patients that had gastric bypass and sleeve gastrectomy maintained that decrease in A1C over that 5-year period. So just like for diabetes, the weight loss surgery works for all of the health problems that are associated with obesity, migraines, sleep apnea, asthma, heart disease, etc. Some of these are hormonally, and some, like back pain, joint pain, that kind of thing, are more mechanical. Now, since Dr. Strong is still in the operating room, I'm going to go through his one as well, and this is looking at the safety profile. When I compare and talk to patients about the safety of weight loss surgery, I think about it in this way. You want to compare the risk of weight loss surgery to what we call usual care or not doing surgery. And when you look at that, there's a small increase of risk with surgery because there's always an increase of risk over surgery, just like there's a risk if you get into your car and go out, drive on the highway versus staying at home. There's a small increase of risk. But just like if you get in your car to go somewhere, the same thing with surgery. You take that very small upfront risk, and we're going to go through what that is, compare that to the incredible health benefits over time, which is quite large. So the upfront risk, and how do you compare it to other things that people may sign up for any day? So some of these are some operations, and looking at the risk profile, and this risk profile was measured in particular in diabetic patients because the risk of postoperative problems or complications is much higher in diabetic patients than non-diabetic patients. They were looking for what the difference risk was in the highest risk category. So up at the top, you can see a CABG, which is a heart bypass with an overall complication rate of 46% when you include all the possible complications. And you can kind of follow that down. So knee arthroplasty, that's a knee replacement. A colectomy, that's a partial colon removal. An appendectomy is appendix removal, so something that is the most common urgent or emergent operation that's performed on the abdomen. And then we get down to gallbladder surgery, hysterectomy, and gastric bypass in diabetic patients. Overall risk of complications of 3.4%, taking all comers of complications or problems. So the safety profile is quite good. And this has changed over time through very diligent efforts of our specialty. If you go back to the year 2002, this was approximately 4 deaths per 1,000 bariatric operations that were performed, which, while that's still very low by percentage terms, that has now dropped to well under 1 over the next 10 years. And that's continued to drop. Obviously, as you start to get this low, it slows down a little bit, but the safety profile is outstanding. Now, shifting from the risks of surgery, which are low, this is a study that looked at long-term outcomes after surgery, especially in patients that have diabetes again, which is a higher risk, and looking at the cardiovascular outcomes, so things like heart attack and stroke. And so this is the what's called the cumulative incidence, or how many times these things happened to patients that were matched, who had surgery and who didn't have surgery. And you can look over these years. This is from 0 to 8 years. In the patients that did not have surgery, that had over 15% risk and a continued decline of heart failure, heart disease, arrhythmia, stroke. And for metabolic surgery, that dropped that rate by just under 10% over those years. And so that's a significant decrease in these diseases in these patients that are higher risk for them. And so this is just one example, heart, and the reason that this study was done is that it's a relatively straightforward thing to measure things like heart attacks and strokes, but it treats your sleep apnea, treats diabetes, increases the safety of childbearing, because many of our patients are younger and are of childbearing age and want to bear additional children. It improves your quality of life so that you are more active, and that activity increases your lifespan. The biggest area of research and the hottest area of research right now is how it decreases risk of certain cancers, treats fatty liver, and many, many more. Almost every area of the body, the health is improved. I'm just going to briefly touch on obesity and COVID infection because while we are still emerging from it, this was a very stark and stark difference between patients who had weight loss surgery and those who hadn't. Early on in the pandemic, we compared the COVID infection severity and incidence in patients with and without prior bariatric surgery who were matched. And of all the people that had COVID, there's much, much less need for hospital admission, ICU admission, long-term living on a ventilator, dialysis, and death. And so this was just one more way, in a way that nobody had really even thought about looking at before. Our group was able to show a huge difference in the overall health of patients after they've undergone weight loss surgery. So with that, I'm going to turn things over to Jamie. Jamie is our program coordinator.
Thanks, Jesse. Hi, my name's Jamie. I'm the program coordinator at the Bariatric and Metabolic Institute. I'm also one of the nurses. Next slide. I'll be talking to you specifically about Cleveland Clinic's bariatric surgical program. So one of the things that's really important when you're choosing where you're going to have bariatric surgery is something that's going to be close to your home. So we make this pretty simple by offering virtual visits for all of your visit types, which it can be done at your home essentially, except for surgery that has not been done yet. But we also offer multiple family health centers. Actually, we see patients at multiple of the family health centers local in our region. And then we also have certified centers of excellence near you as well. So at the centrally located, that's going to be the main campus. On the west side, that's going to be the Fairview and Avon campuses. And then on the east side, that's going to be the Hillcrest and Twinsburg campuses. Next slide. Another really important thing to consider is quality ratings. So U.S. News and World Report has rated Cleveland Clinic one of the best hospitals. And specifically, these areas are really important for you. So the Digestive Disease and Surgery Institute, that's the institute that we fall under, is ranked #1 in Ohio and #4 nationally. Our main campus location in quality is ranked #1 in Ohio and #2 nationally. And then our Fairview location is ranked #5 in Ohio. And then the Hillcrest location is ranked #4 in Ohio. Next slide. Another important factor for our institute specifically and getting you through bariatric surgery is our team approach to bariatric surgery. So it's not just you, it is a group of people. And one of those people is the patient navigator. So that's a caregiver that will be assigned to you, and they're going to help set up your initial appointments. They're going to help to make sure that you're meeting whatever requirements your specific surgery is wanting of you in order to get that bariatric surgery approved. They're going to help kind of guide you through that. And then they're also available weekly for webinars in case you get lost in the program or have questions, anything like that. We know it's a big program, so we want to make sure that we're there to help kind of get you through without any hiccups along the way. Next slide. The other members of your team is your clinical team. So these are going to be your specialists for the medical portion of your workup and for your surgeons. These are all providers that specialize in this field specifically. And so that's going to be a bariatric registered dietitian you'd meet with, an obesity medicine provider, a bariatric psychologist, and a bariatric surgeon. You would have an evaluation by each of these different specialists just to make sure that you're prepared for bariatric surgery and that you're completely optimized. And then we also, so occasionally you might need to see refer to another specialist such as sleep medicine or a cardiologist or something along those lines. And Cleveland Clinic offers many of those providers at multiple different locations and sometimes even virtually as well. Next slide. All right, that was it. That was all I had to say. So I look forward to any questions, and I thank you guys for joining us.
All right, if all the panelists could turn on their audio and video, please remember to keep on sending in questions. I'm going to continue to review them as you send them in. And I'm going to start off with a question directed towards Beth. Beth, how do you manage sort of food around sort of special occasions, holidays, celebrations, that kind of thing?
Well, the good news is a lot of things are too sweet for me or too rich. So that makes it a little bit easier. I kind of go through and see what's going to be served. I do have dumping syndrome if I eat too many carbohydrates or sugar. So that's a really big deterrent. I'm not interested in that. So I take a little bit of whatever I want. I make sure I get my protein, and then I can have a little bit of something else, and I can have enough of a taste that I'm satisfied without having to eat a bunch of it. And I get full quickly, and I just don't want to eat after I'm full. So.
Gotcha. I'm going to take the next one. Someone wanted to know about, you said, well, the risks are small. What are the specific risks? The risks are essentially the same as risks that you would get with any gastrointestinal surgery. So operations on your gallbladder, appendix, colon, small intestine. It's just that essentially we've honed this subspecialty so well that they're lower than the other ones. Those would be leakage from the connections, bleeding, and other sort of problems with anesthesia, like, for example, a heart attack or a blood clot. We, as part of a center of excellence, track all of these and they're extremely low. And one of the reasons that they are is because we do have this huge team approach. So when, for example, you go in for a colon operation, you're not being prepared by dietitians to be eating everything well, checking all your nutritional levels so that you have the nutrition to heal properly after surgery, um, and being screened for all the heart and other types of issues that people can run into afterwards. So part of it's the screening, and then part of it is just over the years how the surgeries themselves have been honed. Hopefully that answers that question. Um, Jamie, as usual, one of the most common concerns is excess skin. Can you talk about how often our patients um, experience that or need a referral for body sculpting because of that?
Yeah, so it's not usually needed in most patients. Most patients, their skin is able to not be as significant of an issue as many people tend to think that it would be. But should you need to have skin removal surgery, that is not something our specific department does, but it's always good to make sure that you have those conversations with your providers on our team so that we can kind of help with documentation. Should you have any kind of like rashes or things like that, because sometimes that can help with insurance coverage from that dermatology or plastic surgeries. And but it's not always something that's needed. And I know a lot of insurances sometimes don't cover it unless it is medically necessary. So that documentation is always going to be really important when you do need it.
Yeah, I think the other thing that I would add is that in addition to this is by far one of the most common questions that patients ask. In addition to skin removal surgery, or if you could call it, or body sculpting as it's sort of medically called, um, one of the most important things are exercises to specifically target the areas where there's more of concern, especially the upper arms and stomach area. And so we also offer referral to physical therapy, in particular for people that have something called diastasis, which is a not a hernia, but it's sort of a loose abdominal muscles after you've lost weight because you've lost weight on the inside of your stomach. And so there are other things in addition to skin removal surgery that can really rehab your body. Even if you, I've had patients that have felt like they needed it, and then really what they needed was a specific exercise program for their abdominal muscles. So another question for Jamie. One a patient asked, my insurance doesn't seem to cover weight loss surgery, which unfortunately some plans don't. Do you have options for people that don't have coverage?
Yes, so we do have a lot of non-surgical options. Our providers here in our department and institute also see patients regularly for non-surgical weight loss. So that is something that our institute specifically can help you with. And the biggest thing for you there is going to be checking to see what your insurance coverage is in terms of, non-surgical options, whether that's medications or seeing a dietitian. Those types of things are going to be important for you to check on before you go to that visit, just so you kind of know, if there's going to be medications that you're going to be able to get or not. And then the other thing that I was just going to add in terms of surgery not being an option is that this is a lot of times a like a workplace driven kind of thing. So your employer could opt into this. And so it might be if you're in a smaller business or something like that, where you have more of a contact with your human resources or your employer, you might want to talk to them about adding bariatric surgery coverage on the next year's plan so that you could try to get bariatric surgery covered.
Yeah, and again, one small thing to add, I've had multiple patients in that scenario, and they've entered our program and worked on the medical weight loss side in the meantime, and talked to their employers, been able to switch it over for the next year, and then the time in the medical weight loss program counted towards their insurance requirements for surgery. So that's a good point
Yes.
to make. Thank you, Jamie. Um, Beth, can you talk about the psychological evaluation and appointments from one person wanted to hear about it from a personal perspective? How helpful was this for you? And then maybe finish it up with like globally why we do them and how other patients feel about them.
So it's a mix of in-person or one-to-one and group, and it's tailored to each person. So trying to tell you exactly how many appointments you're going to need and what kind of appointments you're going to need is going to be a little difficult. In terms of mine, I want to say I had 2 or 3 appointments one-on-one with the psychologist. The first one just kind of gauging where you're at. The second one is second and third ones were just to follow up, make sure I was making progress, make sure my behaviors were changing, make sure I was comfortable with that. The group, there's several different groups. So the group beforehand for me was mindful eating, learning to find other ways to cope and learning to use other things to soothe yourself and cope with life other than so. And I will be honest, I did not want to do the group program, and I actually did find it very helpful. Group things are not my favorite, but I did find it very helpful, and it's nice to hear other people's ideas and to hear other people struggling with the same things you are. So overall, the point of the psychology component of this is to make sure you are ready and able to make the changes to be successful. And there is stress from the surgery afterwards. If that was your coping mechanism, you need to have other things in place to make sure that you are going to be able to deal with life, to make sure that you're not going to hurt yourself trying to eat stuff that you shouldn't, dumping syndrome. Then there are groups available afterwards. There's a couple of them that the clinic does. I know there's other ones that are not clinic related, but there are support groups for after surgery to help keep you motivated, to help keep you on track. Some of them are topic based, some of them are just open discussion.
Thank you. The question is, what is the success rate of meeting the goals, and at what rate do people regain weight? I'm going to break this down into, of course, the answer is depends. So the 3 things that depends on: number one, what operation you pick. The operations are all very similar in terms of their time in the hospital, your recovery, that kind of thing. You wouldn't necessarily know the difference between which one you had by this amount of discomfort, because it's really all the same. But where they're different is, number one, how powerful they are for weight loss and other health issues. Number 2, your risk of regaining weight, and number 3, what their side effects are and the follow-up you need for the vitamins. And I'll go through that a little bit. Second thing it depends on is, what you do with the tool. So how carefully you work with the operation, which is a tool for weight loss. The third is not up to you. It's just your own luck, which is what your genetic background is. Some people, if you had 2 non-identical twins and they both had an operation, one would probably lose more weight than the other, even if they had the same habits, because they're not identical. If you're identical twins, you'll probably get a pretty similar result, and that's just the genetic background. Some people are going to respond more to weight loss surgery, just like you respond more to a medication, for example, for high blood pressure, depending on your genetic background. So getting back to things you can control, the operations, the one that has the least overall power and the highest risk of regaining weight is the gastric sleeve. Gastric bypass is in the middle. That's the one we perform most commonly. And the duodenal switch is the most weight loss and the least likely to regain weight. So the operation you choose is based on your visit with the surgeon, where you're talking about what are your goals, where am I now, where do I want to be, which operation should we maybe look at to try to get to that goal. We also look at what your other health issues are, because that can determine which operation might be best. And then the other thing is what you do with the surgery. So long-term dietary habits, long-term lifestyle in terms of not a ridiculous amount, but a reasonable amount of relatively regular exercise, and then following up with us, because we found that people that follow up tend to do much better with keeping their weight off than people that don't follow up. Someone asked, is skin removal a cosmetic surgery? Some of them are always considered cosmetic. Some are often considered medically necessary, depending on if it's causing discomforts or rashes, something like that. Jamie, could you talk about more? Someone wanted to know more about non-surgical weight loss. Like, what is that? What does that comprise of? The visits, who you're visiting
Sure.
with, that kind of
Sure.
thing.
Sure. So yeah, our non-surgical team is actually the obesity medicine providers. So they would be the people that do your medical workup for bariatric surgery. So all of that testing to make sure that you're safe. But they're also specialists in this field. So they see patients that want non-surgical options as well. And that usually entails a visit with them initially, and then kind of just hearing what are you looking to get. If you're interested in medication options, that might be something that is discussed as certain medications that will help you lose weight, or maybe you just feel like you want to work on diet and lifestyle changes. They can help with that and help refer you to a dietitian, provide recommendations as far as exercise or what you can do, or maybe there's some things from a psychological standpoint that maybe you need to work on. They can kind of help with that too, setting you up with maybe more mindful eating type behaviors. All of that kind of stuff is really what they're going to help you do from the non-surgical component. But usually it's just a visit with that one provider. Sometimes they'll refer you to the dietitian, that kind of a thing. And then you would want to see them back usually every 3 to 4 months. Those follow-ups are going to be important, just to make sure that you're staying on track. Or with obesity, it's a disease that's going to constantly want to fight you and continue to be a chronic thing in your life. And so staying on track with them is going to be important, because you're always going to have to make changes or change what you're doing, just because non-surgical options it's like being on medication for the rest of your life to treat your blood pressure, kind of a thing. I hope that answered that.
Yeah, I think that's perfect. And we have people that go actually back and forth between one or the other. They'll coming in really thinking they want to do surgery, then kind of learn more about it, think about it, and decide they want to try the medical weight loss route instead, which is totally okay. No one will. Often patients are concerned that I'll be upset with them if they want to go that route. That's never been the case. The whole idea is to try to get people healthier. Likewise, some people come in from the medical weight loss and kind of like maybe get some benefits and like those benefits, but want more because surgery is more powerful than the medical interventions, and want to switch over. So there's some questions about wait times and how long this is. This is another common one. Beth, can you talk through some of the differences between why some people have to wait longer or maybe have more hoops to jump through than others for their insurance requirements?
Yeah, a lot of it's based on your insurance requirements. Some insurance plans have no dietitian requirements. Other ones, you have to have 12 dietitian appointments, and they can't be like 12 days in a row. So that can really change how long you're in the program. And that, excuse me. And then it's also a matter of health issues. So if they find out you have sleep apnea and you need to be on CPAP, that's it. That adds a little bit of time to everything. So it all kind of varies. Some people can get through in a few months. Some people it's over a year. It's a matter of how you're doing through the program and what your insurance wants. So that's why there's such a variation in it.
All right, perfect. So people actually are asking some very very interesting questions today, which I really appreciate. Someone asked, is the protein sparing modified diet the medical diet plan? It is not the same as the diet that you're on around surgery. Protein sparing modified fast is a particular special kind of medical weight loss, which you essentially only eat protein for a period of time, and you're monitored by dietitian and physician. It's offered through, and it was really innovated by a couple of centers, one of which was the Cleveland Clinic, and it is a good weight loss option. They're different from what we recommend around the time of surgery, with the exception of when you are on your 2-week liquid diet, you are essentially on a protein sparing modified fast. Hopefully that answers that person's question. It is a good weight loss option, although if you compare that to weight loss surgery, for most patients, it's not as much of a long-term weight loss compared to weight loss surgery, in that the weight regain happens at a much higher rate than after any of the operations. Another person had a question, specific medical question about how do these operations work with type 1 diabetes instead of type 2. These operations will not treat your type 1 diabetes, but they will treat what's called insulin resistance. So over time, you've probably noticed that your insulin requirements have gone up, even though you're a type 1 diabetic. And that's because your body with obesity doesn't use the insulin as efficiently. And so you have to have more and more insulin, which promotes more weight gain. So with these operations, your body resensitizes to insulin, so you need to use, significantly less, probably back to the amount you needed to use than years ago. Another surgical question that was asked: is there any upper limit on weight? This is a common question. The other one is, is there a medical, any medical case where it can't be done? In short, not really. In terms of other medical problems, probably about once a year, I tell somebody it's just the risk-benefit ratio isn't there. So that's out of hundreds of people that I see and take care of over the course of a year. So occasionally it happens, but it's really quite rare. We even offer weight loss surgery for people that have LVADs, which is a pump that keeps your heart pumping blood. In specific cases, we'll offer that. So it's very unusual for someone to not be a candidate medically. Now, we may have to get you ready for it. Similarly, there really is no upper weight limit. Again, we might set specific goals for some amount of preoperative weight loss to allow somebody to recover well, or for the operation to be more straightforward, specifically shrinking the liver before surgery. So we might put you on a special diet, not so much for weight loss before surgery, but really to shrink the liver. But that's done on a case-by-case basis. With that, I think we have covered all of the questions. I did try to leave out some of the personal details. Jamie or Beth, did you see any questions that I missed or didn't cover?
Not and no, I think we generally hit everything for the most part.
Oh, a new one just came in. So can I explain the duodenal switch? Duodenal switch is the least commonly performed of the sort of mainstream weight loss operations, although nearly every insurance provider does cover it. It is kind of a combination of the sleeve and the gastric bypass in some ways. The sleeve is actually the first step in that operation. And after you do the sleeve, you partially bypass the intestines. It's considered a malabsorptive operation. And so because it's malabsorptive, it's the most effective for weight loss. The flip side is you need to take additional vitamins compared to the other ones. You have to follow a specific diet so that you have good quality of life. So it's the most effective, and it's offered in particular for people who have more weight to lose, or people that have in particular significant diabetes, because it is quite powerful for diabetes. There was a question that just came in for Beth. You said you had to get back to work in 4 weeks because you didn't have any lifting restrictions. This person's job is from home. What kind of time do we tell people before they're heading back to work, and what kind of activity level can you do right after surgery?
So, the recovery is a very personal thing. So we want you up and moving after surgery. Walking is good after any surgery, not just bariatric surgery. So people with a desk job that don't have a lifting issue, some people go back in as soon as 2 weeks. That's, again, it just depends on how you're doing, how the diet is progressing, if you're able to meet your goals. Daily exercise, I exercise about 4 times a week. I try to walk every day, though, not necessarily for an hour at a time, but I have a pretty desk job now too, so I do try to move every day. And I see something about vitamin regimen, and yes, I will be on a vitamin regimen for the rest of my life. It's not overwhelming. I just take it like I take any other pill that I would need to take. So I set my alarms to make sure I take them.
And with that, we'll finish up with one more question. Jamie, can you talk about the process from your first visit to when surgery is scheduled? What's the time frame that could be, maybe at the shortest and typical, and then longest? Why it varies?
Yeah, sure. So I think Beth had mentioned that a lot of this program is just kind of driven by what your specific insurance requirement is. That's why it's important to have that patient navigator, because they're going to call and look for what your specific insurance requirements are. They're going to let you know. Some patients don't have any insurance requirements, where you just have to meet our criteria, what our requirements are. We are a center of excellence, and we're certified, and so we have certain things that we want to make sure that you're safe, and those are our standards that we set for every patient. And so you might just have to meet those types of things, but some other people sometimes they have to have 6 months or 6 consecutive months, and that would be meeting with a dietitian or our obesity medicine provider over that course of that 6 months. So during that time frame, we try to just figure out what your insurance requirement is, and then complete all of those requirements and visits, and get all your evaluations completed before that 6 months is done. So once that 6 months is completed, we know, okay, you've met your insurance requirement. We can submit you now for insurance. So it really just kind of depends on that, but also it depends on you as a patient, making sure that you're going to all of your visits and that you're staying on track with appointments, not missing things, communicating when you have questions. Our patient navigation, like I mentioned, has a weekly webinar where you can join in and just ask them your case specific type things. Where am I at? What else do I need to do? Just so that you can help stay on track, so that whatever that insurance requirement is, that's the longest it will take you to complete our program. Usually I think the soonest I've seen people get through is about 3 months. That's usually the earliest, just completing all of those appointments. But then it again just depends on you, the patient, motivation, making sure that you're keeping on track with appointments and stuff like that.
Excellent. Well, with that, thank you to everybody for coming today and this afternoon. And thank you to the panel for spending the late afternoon with us. The next steps, if you're interested, are up on the screen. Essentially, go to our website. We do have you fill out a quick questionnaire so our navigators can check your insurance, so that they can give you a call and let you know what your requirements are. And we hope to see you all soon. And if not in either way, please have a happy weekend.
Have a good weekend. Bye-bye, everybody.